Distinguished colleagues, dear participants, on the first day of the Congress, I would like to thank you first of all for your attentive participation. This topic is important, and due to the fact that we had childhood, adolescent and adult Congress at the same time, this is a focus of interest. And there are certain areas in psychiatry in which the indication for pharmacotherapy is not that high. Somatization is one, dissociative disorders is the other one. However, ADHD has options for therapy, yet it has to be defined further before initiating treatment. In order for it to be diagnosed properly, we have to have certain guidelines which were given to us by the previous speakers. And ADHD can be together with SUD. This was also mentioned. And in this presentation, I will try to evaluate the issue in the presence of the existing treatment guidelines. In this area, worldwide, there are basic guidelines. And British Association for Psychopharmacology has a guideline, and the other, known as CADRA, was published in 2011 by the Canadian Attention Deficit Hyperactivity Disorder Association. Another guideline is from the European Union, and this was published in 2010. Another guideline, known as NICE, is by the National Institute of Clinical Excellence. These are the four main guidelines, and there is a systematic review of national and international guidelines, and this was published in the year 2012. Although we don't see this in adults, in the area of childhood and adolescent ADHD, we have a ADHD guideline in Turkish as well. The proportion of the population receiving treatment for ADHD in the world is still low, and lower than the estimated population prevalence of the disorder itself. And less than 10% of adults with ADHD requiring medication are taught to receive treatment. Both US and UK data reveal this. And untreated ADHD is quite costly to the society when not treated. However, why should ADHD be treated? The first one is that ADHD is a neurodevelopmental condition. There are two main hypotheses. One is the immaturity hypothesis. The second is the disconnectivity syndrome. For untreated ADHD, the results are increased rates of unemployment, increased illicit drug use, lack of academic achievement, poor social adjustment, poor family relation or marital conflicts, and increased criminal convictions. Among all psychiatric disorders, if we are to pay attention, we can think about depression, bipolar disorder, or schizophrenia. In fact, the results are similar to those of ADHD. In that regard, as concerns its results, ADHD is very important. In the pre-assessment for treatment, British Association for Attention Deficit Hyperactivity Disorder has an evaluation scale, and CADRA also has one that will be helpful in the selection of medications. Mental status evaluation is important in the adults, and the history as well as classification and the use of scales. And in Turkey, there is one by Attila Turgay and colleagues. And as our chairperson Sultan Doğan mentioned, she has a scale for adult ADHD. In my own clinic, actually, I mostly use the scale by our chairperson. For that reason, I asked for additional time. There are 18 questions in total, and the individuals should be evaluating this, which is important. In the last DSM-5, it seems to be more coherent with the diagnostic criteria. So we should be evaluating the psychiatric disease history in the family and also doing a differential diagnosis. Among the medical problems, we should take the medical history, weight, height measurements, blood pressure, cardiovascular examination. Auscultation is still a question mark. For cardiovascular diseases, personal and family history is important. Also, liver disease history is also important. For drug choice, individual variability is important, and which symptoms of ADHD are there, and the drug history in the family and accessibility to the medication is important. Other conditions, medical problems and interactions with other medications, combining stimulants with other medications, the possibility for misuse, and physicians' attitude toward ADHD medications. A first-line treatment represents a balance of efficacy, tolerability, and clinical support, and second-line treatments are medications having lower efficacy rates, and third-line treatments are reserved for situations where first-line treatment is of no use. In ADHD, what are the novelties on the path? First, we have new scales and diagnostic tools that have been developed. In the DSM-5, there are novelties brought to us. However, I think they are still insufficient, and recent meta-analysis have calculated and compared effect sizes for most medications commonly used to treat ADHD in adults, which are generally in line with findings in children. This is important for us because mostly we are working in the area of children and adolescents, and most of the medications are used in this age group, and we are trying to benefit from those medications that are studied for children and adolescents. And in contrast to ADHD treatment in children, current guidelines recommend that pharmacological interventions are always first line in adults, and they also recommend pharmacological interventions. And for the efficacy of non-drug interventions, we have limited evidence. Further research is therefore required to evaluate the efficacy of non-pharmacological treatments, particularly in those with mild to moderate levels of symptoms and impairments. And 5 components of treatment. In all the guidelines, the following 5 components are mentioned, and a combination treatment are suggested. Psychoeducation is a sine qua non for those, and the first medication trial, followed by titration to find the individual's ideal dose, assessment of residual symptom, and long-term functioning follow-up. For adults ADHD, in the pharmacological treatment, we have methylphenidate and atomoxetine. In the Europe and the US, diamphetamine is approved, and lisdexamfetamine, which is a product of diamphetamine, is used in North America and certain European countries. If we are to look at the pharmacological classification, ADHD drugs are neurotransmitters, and atomoxetine has a selective noradrenaline effect, and methylphenidate and amphetamine affect noradrenaline and dopamine. Atomoxetine is noradrenaline selective reuptake inhibitor. Amphetamine is a monoamine releasing agent. and methylphenidate is a stimulant reuptake inhibitor. On the other hand, in Turkey, we have atomoxetine and methylphenidate. If we are to compare these, atomoxetine effects are seen through noradrenaline, whereas methylphenidate is through noradrenaline and dopamine. And there are certain advantages, adverse effects, and common effects that are seen. Atomoxetine, the effects is slow, and this is seen as a disadvantage. As adverse effects, we have somnolence. In methylphenidate, we have insomnia. Nausea, vomiting, abdominal pain are seen in both of the medications, as it seems, and loss of appetite, growth weight decreases, and body weight decreases are common. Tics are seen, it seems, in methylphenidate use. Other than these, as for efficacy, they increase cognitive function, attentiveness, and they decrease distractibility and hyperactivity, and they also decrease behavioral disruptions. For adult ADHD treatment in Turkey, these are the 5 main medications in use. These are methylphenidate and different derivatives of methylphenidate. Concerta, Medikinet, Ritalin, and Strattera are the ones that are marketed in Turkey. Among these, concerning the initial dose, it seems to be 18 milligrams for controlled release, and the maximum is 80 milligrams, it seems. For other delayed release forms, we can go up to 80 milligrams. And it also has a tablet form, which is similar to Ritalin. For rapid release, we have Ritalin. We have to start with 5 to 10 milligrams and increase it up to 60 to 100 milligrams. Atomoxetine is sold in the form of Strattera, and you can start with 10, 25 or 40 milligrams. You can go up to 100 milligrams or 1.4 to 2.2 kilograms per day. Methylphenidate formulations. In the formulations, you have the immediate release and modified releases, and these are not equivalents of each other. So Concerta 28% immediate release, 72% controlled release. Medikinet Retard 50% immediate release, 50% controlled release. And in Ritalin and Medikinet tablet, it is 100% immediate release. For short-acting cytostimulants, Ritalin, 20 years of studies have shown us that they may be useful in situations where a top-up of the once daily medication is required, or if the patient desires more flexibility over the dosing schedule. And in cases where the patient wants to be more flexible, this is the most appropriate and the cheapest medication available in Turkey. Atomoxetine, the role of atomoxetine might be varying in the guidelines if there is coexisting substance abuse, anxiety, tics, or sleep disorders, and if the symptoms aggravate in the evenings, this is seen as a valuable treatment option. In adult ADHD, other options are used are off-label. However, these can still be used: bupropion, clonidine, guanfacine, modafinil, tricyclic antidepressants, or low-dose antipsychotics, especially when aggressivity and instinctivity are more often. Co-administration of drugs for ADHD. If the clinical response is limited, in these patients there are limited number of studies. However, combination treatment is effective in these patients, and we have level 4 evidence to support this. In adult ADHD treatment, what are the main consensus points in the guidelines? Stimulants are first-line treatment for adults with ADHD, especially there needs to be a careful titration and monitoring of side effects when the drugs are in use. ADHD drug treatments in adults show similar positive effects to those in children with only slightly smaller effect sizes. Drug treatment should be continued as long as clinically useful. Drug holidays may be useful to ascertain the need of continuation of treatment. Co-administration of drugs is relatively common in clinical practice for resistance cases, but there is a lack of studies investigating its efficacy.
İki dakika, tamam. Pharmacotherapy.
In the management of pharmacotherapy, what are the consensus points? Each patient must be treated uniquely for his or her own features. There is no one medication that is suitable for each and every ADHD patient. The guiding principle for medication is to start slow and go slow for most patients. Some patients may require higher doses to see a clinical effect. It's not possible to identify these patients ahead of time. A result of medication, even when symptoms improve dramatically, an adult cannot be easily normalized, because if a person can carry a lifetime of past scars, lost opportunities, limited education and difficulties, these are not possible to be dealt with easily. However, it should be noted that medication most often needs to be a beginning to a process of rehabilitation. In that regard, in the coming periods, maybe, we can see that clinicians should not oversell the effectiveness of ADHD medications. This is an important dimension, because the patient comes to you with certain symptoms and we have choices for pharmacotherapy. Of course, this is the case. However, we should have caution. And we shouldn't be the ones selling the medication, saying that this should treat each and every symptom. This is not the case. We shouldn't exaggerate the situation. And clinical experience indicates that for some patients, duration of effect is shorter or longer than what is indicated in the product monograph. Switching from a psychostimulant to another medication, I'll be fast here. And the last two slides are related to pregnancy and breastfeeding periods. And so what do we do in those instances? ADHD in pregnancy and lactation are newly recognized, and in the guidelines there are certain data that is being generated. Thank you very much for your attention.